All right, I think we'll start. Welcome to Internal Medicine Grand Rounds. Today's speaker is Dr. Kamal Bhsual from the Endocrine Division. I'll give you a little background. He was born in Nepal, up in the high country, and his hometown was about 4,000 people. But he did well enough to be able to go to the leading institution for medicine in Nepal, which was Triphuran Institute of Medicine in Kathmandu. And then, having finished there, made his way, as some here have and many have, to ultimately a medicine residency in the States, which was at Wyckoff Heights in Brooklyn, New York. So finished his residency there, and from there was recruited by our former chief of medicine, Dr. Banks, to serve down at QEP Long, which was in need of internal medicine. And Kamal was the first one to be recruited down to central Louisiana on behalf of LSU, and others followed from the same residency and others. And so really Kamal was the point of the spear for our affiliations with Alexandria. There he would do clinic for 2 weeks, and then hospital medicine for 2 weeks. And that went on for a couple of years, and then was able to come up here in 2010 and be in our general medicine section, where he did a lot of ward medicine and a lot of medicine clinic and so forth. And that's where he came to my attention, because he expressed an interest in endocrinology. And of course, the first thing we did was ask the medicine residents that we knew, how was he as an attending on medicine? And the answer was he was very good, that he was mentoring and helpful without being unnecessarily intrusive. And that sounded good to us, because that's kind of how we are. And so did his endocrine fellowship from 2016 to 2018, so he's been a staff now for a couple of years. And in that role, he has been great. And by that I mean he's done all kinds of educational things, and is now the Associate Program Director. He's done some life-saving clinical work in the transition from and through University Health and then on to Ochsner LSU. So he's also a fine clinician. And this topic that he's about to talk about is one that kind of is a theme in current endocrinology, which is that classic hormones that we learned about in one context turn out to do other things that are likewise important. And this keeps being repeated over and over. And so this is part of that theme, but it's also part of something that we just encounter all the time. What to do with someone whose PTH is high, but whose calcium is not. So, Kamal?
Thank you, Dr. Scavo. Today I'm going to review primary hyperparathyroidism, and we'll try to give some focus on normocalcemic primary hyperparathyroidism also. I do not have any conflict of interest. Primary hyperparathyroidism is characterized by abnormal regulation of PTH secretion by calcium, resulting in hypersecretion of PTH relative to the serum calcium concentration. Primary hyperthyroidism is the most common cause of hypercalcemia in ambulatory setting. This is one of the commonly asked questions in the board. Whereas in the inpatient setting, it's malignancy. If you have questions that says hypercalcemia as inpatient, what is most likely cause it's a malignancy. But whereas in the clinic, it's a primary hyperparathyroidism. The incidence of primary hyperthyroidism is about 100,000 cases in the USA every year, and commonest age is after 50 to 60 years. And women are more commonly suffering from primary hyperparathyroidism than the men. In the pathogenesis, it depends upon relationship between PTS and ionized calcium. You can see this graph here. There is a steep inverse sigmoidal relationship between the serum ionized calcium and the PTS. The response score is defined by four things. The set point, which is the calcium level at which there is a half maximal inhibition of PTH, the slope of the curve at the set point, and the maximal response of PTH to hypocalcemia, and the maximal suppression of PTH by hypercalcemia. An increase in the first three, meaning set point, hypocalcemia response, or the shape of the curve, or decrease in the response to hypercalcemia will determine how much PTS is going to be secreted from the parathyroid gland. Even if there is no somatic mutation of the gene, expression of calcium sensing protein is reduced in parathyroid adenoma as well as in uremic hyperparathyroidism, and that causes increased parathyroid secretion. And parathyroid secretion from large adenoma may be directly related to their increased cell mass. You can see in this picture, if you have calcium which is low and you have PTS somewhere here, that means it's hypoparathyroidism. Low calcium, low PTS, hypoparathyroidism. If you have calcium here and PTS somewhere here, then that's most likely PTS mediated hypercalcemia, meaning primary hyperparathyroidism. If you have calcium here and PTS is suppressed down here, then it's most likely non-PTS mediated hypercalcemia. In the US, the estimated incidence of primary hyperthyroidism between 1998 and 2010 was approximately 50 per 100,000 persons years. The great majority of cases occurs after the age of 50 to 65. Women are more affected probably because of the increase in bone resorption that follows menopause. In one study, the incidence of hyperparathyroidism was highest among black, followed by white, Asian, Hispanic, and others. And these graphs show same thing: women more likely to suffer than men. And again, this one is age-adjusted incidence, same thing. And this graph shows the black population, both men and women, both common in increased incidence in the black populations than other races. What are the etiology of the primary hyperparathyroidism? In a possible cause of primary hyperparathyroidism, usually we cannot find, but some cases may be related with past history of radiation. And there's some case series or case report. Primary hyperparathyroidism is associated with radioactive iodine treatment we give for hyperparathyroidism or for cancer treatment, thyroid cancer treatment. And sometimes it is associated with genetic inheritance. It may be sporadically or familially pattern, which include gain of function change in genes such as cyclin D1, BRAD1 for sporadic tumors, whereas RET for familial tumors. Loss of function mutation in genes such as MEN1 or CDC73 for sporadic and familial tumors can occur. Is the low calcium intake also likely cause for primary hyperparathyroidism? So good questions was answered by this study. If you look at here, this is the group, with no calcium supplementation. This one up to 500 milligram of calcium per day supplementation. This one is more than 500 milligram of calcium per day. If you look at the relative risk of primary hyperparathyroidism, if you are taking at least 500 milligram of calcium, your risk is less by 31%. If you take at least up to 500 milligram, risk is less, but not that much. Maybe with multivariate relative risk, it's up to 18% less than other, compare the other population who doesn't take any calcium at all. This study clearly suggests, maybe low calcium intake may be associated with primary hyperparathyroidism. Pathological condition associated with primary hyperparathyroidism. Most common is adenoma, single adenoma, 80 to 85% of cases, and there can be multiple, up to 2 to 5% of cases. And glandular hyperplasia, maybe or whole gland hyperplasia, may be associated with 4% of cases, and very rarely you can have parathyroid carcinoma, up to 1 to 2% of cases. And other familial condition associated with primary hyperparathyroidism include familial hyperparathyroidism associated with the MEN1 syndrome, familial isolated hyperparathyroidism, familial hyperparathyroidism with jaw tumor, MEN2A, and you can have unmasking of occult primary hyperparathyroidism if you start them on thiazide diet because it reduces urine calcium excretion and increases mild hypercalcemia, and you may not have noticed before. Now you notice that patient might have primary hyperparathyroidism. And lithium therapy is associated with the primary hyperparathyroidism. It decreases parathyroid gland sensitivity to calcium, shifting the set point of the calcium PTS curve to the right, and it can cause foregland hyperplasia. That's why it's important. If you're sending this patient for surgery, probably if you remove 1 or 2 or 3 glands, it may not cure the disease. What are the clinical features of the primary hyperparathyroidism? Most of the cases nowadays are asymptomatic. 80% cases in the Western Hemisphere. You can have normocalcemic primary hyperparathyroidism, or you can have rarely patient presented with parathyroid crisis, which is 1 to 2% of total parathyroid case. And it includes severe hypercalcemia with calcium more than 15, and marked symptoms of hypercalcemia, mainly CNS dysfunction. It can be associated with abdominal pain, nausea, vomiting, peptic ulcer, and pancreatitis, and maybe related with intercurrent illness like and then with volume depletion and infarction of the parathyroid adenoma. Or you can have classical presentation related to combined effects of increased PTS as well as high calcium. You have heard this sentence: bones, stones, abdominal moles, and cyclic groans. We usually don't see with all these symptoms nowadays. If you classify those symptoms based on the system, you can look at in this graph. Due to high parathyroid, can be signs and symptoms of hypercalcemia, and can be because of bone disease or nephrolithiasis, hypophosphatemia, increased production of calcitriol, proximal renal tubular acidosis, hypomagnesemia, hyperuricemia, and gout, and anemia. And just due to high calcium, you can have polyuria, polydipsia, nephrolithiasis, nephrocalcinosis, distal renal tubular acidosis, nephrogenic DI, acute and chronic renal insufficiency, anorexia, nausea, vomiting, bowel hypomotility, and constipation, pancreatitis, peptic ulcer disease. And you can have muscle weakness, vague symptoms like fatigue, muscle weakness, bone pain, osteopenia, and osteoporosis, decreased concentration, confusion, fatigue, stupor, coma, and you can have shortened QT interval bradycardia as well as hypertension. How they present nowadays as compared to previous? In 1930s to 65, majority of cases would present with nephrolithiasis, up to 60% of the cases, and maybe about 22% of cases presented with bone disease. That is changing. Nowadays, 80% of them is asymptomatic, only few of them, about 19% of them, present with nephrolithiasis, and maybe 3, 4, 5% maybe with advanced bone disease. That may be because we are screening calcium, unlike 1930s and 65, we're doing calcium for all patients, for all routine visits. That's why we're diagnosing them well ahead of time before they develop complication. Other clinical features include a rheumatological manifestations not common. You can have hyperuricemia and gout. You can have pseudogout. You can have calcification of articular cartilage. You can have pseudogout even after parathyroidectomy. Other important points, 17% of asymptomatic primary hyperparathyroidism can have GFR less than 60. You may not see anything, but if you look at the GFR, probably their GFR is less than 60. A higher frequency of them are associated with impaired glucose toleration and diabetes, but not all studies prove this. In meta-analysis of 13 studies, primary hyperparathyroidism thyroid patients were 3.3 kg heavier in average than the control, and their BMI was about 1.1 kg per meter square, were higher than the control. But one study showed the parathyroidectomy didn't change their BMI. There's no benefit after surgery. For cancer, there's conflicting data. Some studies says it increased cancer risk, but some of them didn't show that. For mortality risk, it is associated with increased mortality if you have severe classical primary hyperparathyroidism, mainly due to cardiovascular disease. This is the diagnosis is very rare, osteitis fibrosa cystica, but it's not rare in the board. You'll see these questions and images of osteitis fibrosa cystica all the time in the board. That's why we need to know these cases also. It's very rare here, but it's still common in third world. It is characterized by bone pain, and radiographically you can see periosteal bone resorption on the radial aspect of the middle phalanges, tapering of the distal clavicles, a salt and pepper appearance of the skull, bone cyst, and brown tumors of the long bones. Brown tumors results from excess osteoclastic activity, and it consists of collection of osteoclasts intermixed with fibrous tissue and poorly mineralized woven bone, and the brown coloration is due to hemosiderin deposition. This is the skull of osteitis fibrosa cystica. This is the classic sandpaper texture here, salt and pepper texture, and this one, same patients 6 months after parathyroidectomy, completely normalized. Subperiosteal resorption, and you can see small brown tumor here. Again, subperiosteal resorption, and then resorption of subchondral area, subchondral resorption in the clavicular hair here. And this is the pelvis. If you look at here, these are the large brown tumor. What are neuropsychiatric complaint? They can complain lethargy. They will have depressed mood, psychosis, decreased social interaction, and cognitive dysfunction. After parathyroidectomy, depressive symptoms, nonverbal abstraction, and some aspect of verbal memory significantly improved. You can see those here in this graph. The depression improved significantly. State anxiety didn't improve significantly, but the trait anxiety improved here based on this data. And again, this one is for short-term memory. It's a memory improvement. Longer bar means improvement. This one is for immediate and delayed memory. Again, there's improvement here also. And this is nonverbal abstraction. It's improvement after parathyroidectomy. Let's start with the case now. We had a 40 female with a past medical history of multiple nephrolithiasis since age 19. She was referred for evaluation for possible primary hyperparathyroidism. In summary, since the age 19, she reported recurrent nephrolithiasis, and she was seen by urology multiple of times. She had 2 stent placed, and lithotripsy at least 12 times, he said. And as per stone analysis, we didn't have the report, but patient said it was calcium oxalate stone. We reviewed the lab, and it suggested normal calcium and slightly elevated PTH. What should we do now? Calcium is normal. What do we do for evaluation of suspected primary hyperparathyroidism? If there is hypercalcemia, you confirm with the albumin and corrected calcium. If it is still high, then you proceed with the repeat calcium with ionized PTH. And if ionized PTH as well as calcium is high, then you have primary hyperparathyroidism. But if you have elevated calcium but low PTH, that's not primary hyperparathyroidism, it's non-PTH mediated hypercalcemia, maybe malignancy or something else. If you have high calcium and mid-upper normal or minimally elevated PTH, then it can be primary hyperparathyroidism, or it can be familial hypocalciuric hypercalcemia. This is commonly tested in the board for internal medicine resident. You need to know. How do you differentiate familial hypocalciuric hyperparathyroidism versus primary hyperparathyroidism? The FHS will have long-standing mild hypercalcemia. If you have old labs, 5, 10, 15, 20 years from today, they will have slightly high calcium throughout their history, and there might be family history of hypercalcemia. And you do 24-hour urine calcium. If you don't have any information or you want to confirm it. If calcium 24-hour urine calcium is more than 200 milligram, then this one is primary hyperparathyroidism. But if calcium is less than 200, it still can be primary hyperparathyroidism with vitamin D deficiency and or low calcium intake, which is very common in our patient. Or it can be familial hypercalciuric hyperparathyroidism, hypercalcemia, sorry. What you do next is replete vitamin D. If vitamin D is low, give vitamin D. Advise them to take calcium, increase calcium intake at least 1,000 milligram per day. That's the national, the normal recommendation. And repeat 24-hour urine calcium. If repeat 24-hour urine calcium is more than 200, or calcium creatinine ratio, you can do serum calcium creatinine also at the same time and calculate calcium creatinine ratio. This is simple ratio, but you can calculate FICA, that's what I mean, fractional excretion of calcium. If the calcium is more than 200 and the ratio is more than 0.02, then you have primary hyperparathyroidism. If calcium is less than 100 and that FICA is less than 0.01, then your diagnosis is familial hypocalciuric hypercalcemia. You need to order genetic testing for calcium sensing receptor mutation. What are additional evaluation we should do for somebody who is suspected to have primary hyperparathyroidism or confirmed primary hyperparathyroidism? Urine calcium, if we have not done before, vitamin D, serum creatinine and GFR, DEXA scan, renal ultrasound to assess for occult kidney disease like nephrocalcinosis or renal stone, and spine X-ray to assess for asymptomatic vertebral compression fracture. Other tests may be useful. Phosphorus usually are low in primary hyperparathyroidism, whereas in secondary, especially in CKD and ESRD, it will be high. Bone turnover marker can be useful sometime, and biochemical renal stone assessment sometimes needed to look for indication for surgery. The localization study with ultrasound, sestamivi scan, CAT scan, or MRI should not be used for diagnosis of primary hyperparathyroidism or to determine what can be a management. But if patient is going for surgery, then you can order those as a part of the localizing study that will help the surgeon. What is normocalcemic primary hyperparathyroidism? In 2009, an international panel of experts recognize this phenotype of primary hyperparathyroidism as a phenotype of primary hyperparathyroidism, in which PTH levels are elevated, but serum calcium is normal. In order to make diagnosis, you should rule out secondary hyperparathyroidism and ionized calcium. You should order ionized calcium, and that should be normal also. If it is high, then it's the regular classic primary hyperparathyroidism. What are the causes of secondary hyperparathyroidism? If you have normal calcium and high PTS, look for these causes: CKD, decreased calcium intake, calcium malabsorption, vitamin D deficiency, celiac disease, bariatric surgery, pancreatic disease, renal calcium loss. If you don't have anything, do urine calcium. If there is hypercalciuria without any known cause, that might be the reason why PTS is high. And loop diuretic can cause high PTS. The inhibition of bone resorption, those medicine, look for those medicine, bisphosphonate, denosumab, or a patient had hungry bone syndrome. Is there any formula that can differentiate primary hyperparathyroidism or secondary hyperparathyroidism with normocalcemic hyperparathyroidism? Somebody tried to answer that, and they have a formula. It was published in 2016, and look, they claim it has 95% sensitivity and 89% of specificity. And this is the formula. Good luck with this. Okay, multidimensional PTS, predictive PTS, okay, equals minus 32.6, starts from minus 32.6 plus 0.0197 times is plus 0.00424 times 25, vitamin D plus 2.85 times calcium level plus 0.433 times PTS, square root of PTS. Actually, it works. I tried to calculate on my patient actually, but it takes 15 minutes to calculate, and your as per our follow-up time would be that 20 minutes per patient. You will spend time calculating just this one in your follow-up time. If you calculate this one, and if it is more than 0, then it's highly probable that patient has primary hyperparathyroidism. And if it is less than 0, it's more likely to be normal or secondary hyperparathyroidism, depending on vitamin D status. If it is 0, 50% chances that patient have primary hyperparathyroidism. There are some study, there's not many, a few studies. One of the studies with 37 patients of normocalcemic hyperparathyroidism, they followed them for 8 years. 41% developed, in 8 years, 41% developed evidence of progressive hyperparathyroidism disease during median 3 years of observations. Less than 20% of these patients became hypercalcemic, suggesting maybe they were earlier stage of classic primary hyperparathyroidism. Some persistently normocalcemic patients develop other indications for progressive disease such as kidney stone, hypercalciuria, bone loss, and fracture. 4 individuals went for surgery and had successful surgery. There's no data to suggest that all these patients will ultimately become hypercalcemic, and over what period of time. Since most of these patients were identified in the course of an evaluation for osteoporosis, fracture, or low bone density, they may not represent an early form of asymptomatic primary hyperparathyroidism, but could instead represent a unique phenotype of the primary hyperparathyroidism. This graph shows what was the percentage of the bone disease on normocalcemic primary hyperparathyroidism. Their calcium were normal, but the PTS was high. And when they analyzed, 34% at the lumbar spine, 38% at the hip, and 28% at the distal radius, they had osteoporosis. So almost 1/3 of those people had osteoporosis. And this is another study, and this one again shows 29% with normocalcemic primary hyperparathyroidism, whereas 33% in classic primary hyperparathyroidism is associated with osteoporosis. It's equal, almost equal. what should we do for this patient? If you're not doing anything, at least monitor them with calcium and PTS annually and DEXA scan every 1 to 2 years depending upon situation. If they progress to hypercalcemic primary hyperparathyroidism, follow the guideline. If they meet the criteria for surgery, send them for surgery. And if they have progression of disease but the calcium is still normal, worsening of BMD or fracture or kidney stone or nephrocalcinosis, probably you need to send them for surgery. What happened to our case? Let's come back to our case. You remember that case with the multiple renal stone with normal calcium and high PTS I presented earlier? We looked at the lab. I had this much of lab. We had one lab from 2011, a couple of lab from 2017. Calcium were normal, all of those. Ionized calcium we did that day was normal. Corrected calcium also normal. Creatinine normal. PTS was high, 116, with relatively okay vitamin D, not that low. And phosphorus was low normal. And we did the spot urine calcium creatinine ratio to calculate how much calcium is secreting there. It's 94.33. It's kind of lower side, but not that low. And we looked at the image from outside. She had ultrasound already, and this is the outside image, and this is our ultrasound here, and both of them showed an area here in the left side of thyroid lobe, behind left side of thyroid lobe, looking like a maybe thyroid nodule versus parathyroid adenoma. And we looked at the CAT scan. We had some CAT scan image available. If you look at here, stone, multiple stone, multiple stone. Again here, multiple stone. And that day, I just copied this one from the fellow's note, what we recommended. Yeah, hyperparathyroidism with nephrolithiasis, normocalcemic hyperparathyroidism, history of recurrent nephrolithiasis. For patient, renal stone profile showed calcium. Differential can be primary hyperparathyroidism versus idiopathic hypercalciuria. Currently not taking enough calcium and vitamin D. We recommend replacement, and we'll complete 24-hour urine calcium, creatinine, and other renal stone profile. Refer her to our urology here. And we decided to do FNA there in the clinic. Somehow that FNA turned out that it was benign follicular nodules. I'm not sure. The needle was only within the thyroid lobe because it was behind the thyroid, or it was true. A PTS washout came back only 16, which is very low. If it was true parathyroid adenoma, it should be in 1,000. If not in 1,000, it should be in 100. And subsequent follow-up, we didn't do much that day because calcium normal, slightly high PTS. We wanted to do more workup and all those things. Patient was not happy, so she came back for follow-up. When she came back for follow-up, had another bouts of abdominal pain and followed by lithotripsy, 11 more stone removed, and out. It was in the outside hospital in 2 different admissions during that time, in few months again. And again, this time we had that stone analysis report. It says calcium oxalate stone. And we had more lab. And these are the repeat lab. Calcium again normal, ionized calcium again normal, albumin good, phosphorus good, creatinine good, PTS again high, slightly high. 25 vitamin D was okay here, slightly lower here, and 24-hour urine calcium was only 75. I'm not sure she started to take calcium or not. Due to severe and multiple recurrence of calcium renal stone, it was decided to send her for parathyroidectomy. If parathyroid scan also localized parathyroidism, we don't need to do parathyroid scan for diagnosis of something, that's what I said, but this is a unique case. This is not covered by guideline. We decided to do parathyroid adenoma, and if parathyroid adenoma, the parathyroid scan localizes disease, maybe we should consider sending her for surgery because of that recurrent stone. And we have this parathyroid scan, which says suspected enlarged parathyroid gland, likely to be the left superior parathyroid. If you look at here, this one, with this uptake, increased uptake here as compare if you compare it with the other side, here, here, and again here. And this is from the behind. This is left side. And we sent her for surgery. Surgeon agreed, even if calcium was not high. It took few hours. It took few hours to explore her suspected parathyroid. It was 3-4 hours actually. She had to call me in between. Should we proceed or not? Because she had difficulty finding the parathyroid. But ultimately she did. Ultimately, intraoperative PTS, what they do is they order they do intraoperative PTS. If PTS drops more than 50%, we got the right disease parathyroid. And patient started with 140 PTS. It dropped to 83 with some resection. She had to do multiple resection. Didn't drop 50%, again 75 with a third resection, and then ultimately dropped to 30. And it was decided, okay, we got the culprit, let's close it. And path report came back. A few benign thyroid tissue because they were removing so many tissues suspecting parathyroid. Thymus also, and couple of parathyroid gland. Largest one was 0.1 gram, which is 100 milligram. That's 2.5 times normal. That was enlarged. And one is left superior and other possibly inferior. It's not clear. What happened after surgery? No stone. After that, PTS normalized. No hypocalcemia, and patient is very happy. Okay. What are the management of primary hyperparathyroidism? Surgery to remove abnormal disease parathyroidism is the only cure for primary hyperparathyroidism. It cures the disease, decreases the risk of kidney stone, improves the BMD, decreases the fracture risk, and modestly improves some quality of life measurement. And criteria for surgery is if patient is symptomatic, they go for surgery. If they are asymptomatic, then we need to find the other indication. Even if there is no indication for surgery, it is an established and appropriate treatment because it is the only cure. There is no other cure if you want to cure the disease. And this is the latest guideline for the indication for surgery. If your calcium is 1 above the upper limit of normal, this is very controversial now. If you realize, have you realized the lab, what is happening with the labs now? Since December 1st, they are doing the assay, calcium assay, the same assay. The previous upper limit was 10.1, now it's 10.5. Previously, same patient would qualify for the surgery with 11.2 calcium. Now if you look at the upper limit in our lab, it's 10.5, you need 11.6. Although the assay was not changed, I don't know what was the basis for that, but that's like different questions here. But if your calcium is more than 1, then they go for surgery. If you have DEXA scan and they have osteoporosis, including on the distal radius, they go for surgery. Or if you see a fracture in the X-ray or MRI or CAT scan or in the VFA, they go for surgery, even if your DEXA does not show osteoporosis. If you have a renal stone, they go for surgery. If GFR is less than 60, they go for surgery. 24-hour urine calcium more than 400, and with increased stone risk with the biochemical stone risk analysis. You have to do stone risk analysis on the 24-hour urine. And then if that shows increased risk, then they will go for surgery. And if there's a stone or nephrocalcinosis also in X-ray or ultrasound or CAT scan, they go for surgery. And age 50. Younger patient with primary hyperparathyroidism, all of them will go for surgery. This one shows changes in bone mineral density at 3 sites, lumbar, femoral, and radius, if you follow primary hyperparathyroidism patient for many years. So they will lose more bone here in the radius, distal radius, than in the femur and the lumbar spine. But what happens after surgery? If you do parathyroidectomy, lumbar spine's bone density increases more than radius. I don't know why. Although these are more to lose when you don't do surgery, But if you do surgery, they don't gain those density. The benefit will be there in the lumbar spine or in the femoral neck. Similar result on this one also. This table shows what happens if we send them for surgery in terms of kidney stone. They have 12 patients, 1 year and 10 years, they didn't have recurrence of the stone. Calcium level, baseline was 10.8, improved 9.1, 9.4. PTH improved, urine calcium improved, serum alkaline phosphatase improved. But after 10 years, it was similar to baseline here. This one, what happens if you do surgery here, the patient got surgery and their recurrence stone risk or their incidence of a stone decrease over time. This one is 90%, about 90% of them remains stone free. It's not 100% sure that they will not have another stone. What kind of surgery? Usually minimally invasive parathyroid surgery is the standard of care with an experienced surgeon. This is very tricky, experienced surgeon. If you don't have experienced surgeon, probably you will not remove the diseased parathyroid, number one. Number two, you'll have more complication. Cure rates with minimally invasive surgery exceed 95% with the experienced surgeon, of course, and complication rate is 1 to 3%. How they know whether they got the culprit or not? By monitoring intra-op PTH. If it is dropping by more than 50%, it confirms that they have success. What are non-surgical management of primary hyperparathyroidism? Those patients who had severe comorbid condition, they may not go for surgery, or if they decline surgery, what are other options? Or in certain situations, like patient is pregnant, first trimester pregnancy, second trimester pregnancy, you can then for surgery if needed. Severely limited cervical access, prior vocal cord paralysis, short expected lifespan. They are not going to go for surgery. Currently, there is only one medication that lowers calcium, that is sinacalcet. It normalizes calcium in 70 to 80% of patients, but it does not have benefit of the bone mineral density, hypercalcemic symptoms, kidney stones, or quality of life. The bisphosphonate should be used if patient has low BMD or who has fragility fracture, not the sinacalcet. Replace vitamin D if vitamin D is also low, so that it will reduce further parathyroid hormone level rise. And combination of bisphosphonate and sinacalcet is an appropriate option if patient has high calcium as well as they have osteoporosis. And denosumab is another option for bisphosphonate. I had another case, 57-year-old male with past medical history of hypothyroidism, started post radioactive iodine ablation and total thyroidectomy for Graves' hyperthyroidism. And his other medical problem was hyperlipidemia. He came for follow-up. I see him for hypothyroidism for many years. And one day, apart from his regular problem, he wanted to discuss about possible hyperparathyroidism because his wife was recently diagnosed with primary hyperparathyroidism, and some of the symptoms like mental fogginess, difficulty to concentrate, and bone pain was also present in his case. What should I do? I went with the patient, I ordered renal function panel, PTS, and vitamin D. And the result came back, this one. Calcium was 10, albumin 3.9, still normal calcium. I didn't do an ionized calcium at that time. Phosphorus was 3.9, creatinine normal 1.2, above 60 GFR, 25 vitamin D 15.4, low, PTS 93.4. What does it indicate? Patient may be right. He might have hyperparathyroidism, or maybe not. His vitamin D is low. My diagnosis was secondary hyperparathyroidism due to low vitamin D. And I started him a high-dose vitamin D and planned to repeat lab. And he came back for more labs and for follow-up. This is the lab now. Calcium 10 to 9, it's more normal now. And again, all other labs normal. Vitamin D is also normal now. The PTS is higher than before after replacing this vitamin D. PTS went up, didn't go down. If it was secondary hyperparathyroidism because of vitamin D deficiency, it should have been normalized. It did not. I did urine calcium creatinine ratio from the spot urine. It's 132, not bad. I mean, not too low, not too high also. And I also did 125 vitamin D just for academic interest. It was normal. What is it now? I was wrong based on this lab, right? I questioned this lab, the PTS. Maybe our PTS assay was a problem. Maybe he has some interference in his serum, and that is giving wrong PTS. PTS probably was wrongly high. And what I did, I sent the PTS from the same sample to outside lab with a different assay. And that came back again high, right? 78. Their upper limit was 64. Is it still secondary hyperparathyroidism now? No. It is a case of normocalcemic primary hyperparathyroidism. And I decided to order more tests to look for indication for surgery. More labs. 24-hour urine came back very generous, 296, as if it is a primary hyperparathyroidism, classical one. Renal ultrasound, no stone, DEXA, osteopenia, no osteoporosis. Neck ultrasound didn't show any possible parathyroid adenoma. Only indication for surgery at this time, if I am treating this patient as if it is a variant of primary hyperparathyroidism, then low GFR. GFR was 55 on subsequent lab. And patient wanted to go to the Advanced Center for Parathyroid Surgery, and he was referred to Norman Parathyroid Center in Florida, where they just do parathyroid, nothing else. And he went there. And I got the up note from surgery. It says sesame may be scanned in the morning with localization to the left. They did parathyroid scan on the day of surgery. Taken to the OR while still radioactive for intra-op nuclear mapping and parathyroidectomy. Two enlarged hypersecretory parathyroid glands were found, right lower and left upper, and PTS production from each enlarged gland measured. They have method to measure PTS production from individual gland. It was 178 and 154 from those, and post-op PTS dropped to 5.3. Two perfectly normal parathyroid glands were identified. They were biopsied. I left it alone. And pathology confirmed that they were the removed tissue were parathyroid tissue. And they also sent the picture. And this is the left and this is the right. What happened after that? PTS normalized. Patient is feeling better after surgery. His mental fogginess has improved. His memory has improved. He has more clarity, and bone pain has gone. In summary, primary hyperparathyroidism is common and can be associated with several complications. Only curative treatment is surgery for primary hyperparathyroidism. Look for indication for surgery. Surgery normalizes calcium and parathyroid hormone level, reduces the risk of kidney stone, improve bone remodeling and skeletal health. It may also have other cardiovascular, renal, neurological and GI benefit. If surgery is not an option, cinacalcet lowers calcium but no other benefit there. Treat with bisphosphonate if there is osteoporosis. If you have normocalcemic primary hyperparathyroidism, normocalcemic primary hyperparathyroidism is also not uncommon in our patients. Look for it. If you have nephrolithiasis or unexplained CKD, if you have low bone mass and other symptoms of primary hyperparathyroidism, then look for the possibility of normocalcemic primary hyperparathyroidism. There is no established guideline for normocalcemic primary hyperparathyroidism. If needed, patient can be sent for surgery if they meet criteria for asymptomatic primary hyperparathyroidism. Any questions?
You know, in renal failure, in early CKD, you don't see hypercalcemia. I have a couple of patients who have hypercalcemia when they are in CKD 2, CKD 3. But those patients have hypercalcemia at times and normocalcemia at other times.
Yeah,
What would be the explanation for this, up and down calcium level?
Yeah, many patients with the classical primary hyperparathyroidism also can have occasional within the normal range calcium, and sometimes slightly high. That's why it's high normal or slightly above normal is the classic phrase you have to use for the primary hyperparathyroidism.
Thank you so much.
Thank you.
Great presentation.